Hey there guys, I'm back. This is Barbara Garcia for Path 370, and now we're talking about pulmonary disorders in Chapter 22 and Chapter 23. Chapter 22 is gonna talk more about obstructive pulmonary disorders. Remember, anything that slows the intake of air. So air going inward is going to be like slowed down by a narrowed bronchiole or slowed exchange of gases through the alveoli. Restrictive disorders are more of fibrotic, and those are going to be in Chapter 23, right? So anything with fibrosis that is going to prevent the lungs from expanding properly. So you want to make sure you know the difference between obstructive and restrictive disorders, because that's really just like the primary thing you want to lay down as a foundation. All right, so obstructive pulmonary disorders, right? Increased resistance to airflow. So anything about air moving in where there is a decrease in the ability of the air to get in, okay? So obstruction, right, from the conditions of the wall of the lumen anywhere along the line, right? Bronchi, bronchioles, wherever it may be, right? Obstruction in the airway lumen, obstruction or resulting from increasing pressure around the outside of the airway lumen. All right, so one of the most common obstructive pulmonary disorders is asthma, right? So an obstruction, right, that is reversible. And that's not necessarily always the case, but for the most part, it has to do with inflammation, and the inflammation can be reversed. Some patients have what we call status asthmaticus, which means they are constantly in a state of obstruction and they have asthma basically all the time. All right, so this asthma can be from many different causes, usually some sort of chemical or allergen, right? That becomes the stimuli with which the bronchioles are going to spasm and become narrowed, right? And then if you're asthmatic, you're going to start to see an increase in the smooth muscle. The diameter of the lumen becomes smaller, and there's also an increase in the mucus production. And so all of those things are going to, since there's more mucus glands, right, more smooth muscle that narrows the lumen. And then when there is a stimuli, then that smooth muscle narrows even more and then really causes an obstruction. This is seen in about 5 to 12% of the U.S. population, right? And it is the most common chronic disease of children, you know, as they're getting used to exposure to so many different allergens, right? So two types, right? You have non-allergic, which is the adult onset, and allergic, which gonna see much more in children. All right, so that's what we are going to differentiate between an intrinsic, right, non-allergenic for the adult onset, and then the extrinsic, it's something coming from the outside, right, in the pediatric onset. All right, so extrinsic, about 1/3 to about half of all asthma cases are going to be an IgE-mediated response to some sort of allergen, right? So what are we going to do, right? Pharmacological therapy that could involve rescue inhalers. It could involve a nebulizer or something of that nature for the immediate resolution, right? And then in the long term, you could do some immunotherapy, right? So immunotherapy is going to provide you like needle pricks of increasing concentration of the allergens that are causing the problem, and starting from a very, very dilute dose, right? Very small dose. And so what that does is that it introduces the allergen into the body, and then the person can get more and more accustomed to that allergen, and basically the allergic response can go away. This is very useful in children, not as useful in adults. So it's not very much that can be done in adults. Now, of course, there's always the ability for you to control the environment around you. So the environment, if it's dust, if it's, grass, or whatever the case may be that is environmental, then eliminating that would also help cure a allergy-induced asthma case, right? So intrinsic asthma usually develops in adults around middle age, and it's much less favorable diagnosis, right? Usually has nothing to do with allergy. Probably comes on due to some sort of respiratory infection, right? Where the respiratory infection is going to cause maybe a buildup of mucus or an overreaction to that, the narrowing of your bronchioles, right? And psychological factors as well, right? They usually appear to contribute. And then, so immunotherapy and environmental control are not helpful for this type of asthma. All right, there's another type of asthma, right? Exercise-induced asthma, common in children and adolescents, right? Where you see that bronchospasm within about 3 minutes after the end of exercise, and it resolves on its own, usually within about 60 minutes. Right, so it is seemed to be mediated by like an increased osmolarity, right? So that you see a heat loss, water loss, right? And then that basophils and mast cells, right, causing a smooth muscle contraction in response. So most you will see in, running, jogging, and tennis are those common stimulators for that exercise-induced asthma. And then occupational asthma, right? So there's some sort of allergen that is found at work that the person is having a response to. So they may need to have, right? It could be progressively worse. So sensitization is not a very effective treatment for this type of occupational asthma. It may need to conduct some tests to find out what it is about in the environment that is causing the asthma. All right, so there could be drug-induced asthma, often seen with aspirin or NSAIDs, right, where there is rhinorrhea, which is basically, runny nose, right, and then respiratory arrest, reading even up to the need of mechanical ventilation, and then some food additives as well. You will see that yellow dye number 5, tartrazine, and MSG sodium potassium metabisulfate, or even the hops in beer. All right, so what are the pathogenesis seen in asthma, right? So some of the immunohistopathologic features, so look at that word, right? Immunohisto, right? So immuno having to do with the immune system, histo having to do with the micro anatomy, and then pathologic features, right? You might see edema, and very likely to see mast cell activation. So mast cells, remember, secrete histamine and heparin. So in releasing your histamine, you can see that that could cause a bronchoconstriction, as the function of your mast cells is really more for the vasodilation, but you know that having that beta receptor is going to cause mast cell, the histamine will cause bronchoconstriction. Right, and so you might also see neutrophils, eosinophils, and lymphocytes having some effect in inflammation as well. So, and it causes this bronchoconstriction or acute bronchospasm, right? And I mentioned that one of the things that you're going to see in increase in your patients with asthma is they're going to have an increase in the mucosal the mucus producing cells, so mucosal glands in the membrane, right inside, like the lamina propria layer, right, the connective tissue layer just inside the epithelium of your bronchi and bronchioles. You might see an increase in mucus production because of these increased number of mucus glands, right? So you might see even mucus plug formation, right? And then you'll see an increase in the size of the wall. So you might see an increased mucosal, right, glands, and then you also might see an increase in smooth muscle. So all of those make your airway thicken, the airway wall thicken, right? So which disease has increased airway responsiveness to various stimuli? Well, be it that the only one we've talked about so far is asthma, we're going to go with that, right? And we'll talk about the other ones. Right, so you can see here a normal wall of the lumen there, and then this one with the much greater amount of mucus glands, and so the narrowed lumen of an asthmatic on the right. All right, so again, the IgE mediated response is very common, right? So you'll see very elevated IgE levels. You might see even eczema, even allergy, and usually very seasonal can be seen as well, depending on which plants they might find to be very allergic to, like in South Florida, mango pollen, right? Mango flowers are very high, right? So a lot of people who come to South Florida from areas in which there are no mangoes, right, which are pretty much the rest of the United States, they are gonna be kind of in shock at how much mango flower pollen there is in the air, and often are gonna start having reactions to that, and allergy, usually in the allergic form, so some allergic response. And then environmental and occupational exposure. All right, mechanism of action. So what is happening here, right? The mechanism of action, some sort of antigen, right, that you have previously received some sort of sensitization to, right, is going to release histamine from mast cells, right, and the antigen reacts with the antibody, releasing a chemical mediated substance. So cytokines are going to be those very important inflammatory mediators that are going to be released when you have the antigen antibody bound. All right, so normal respiratory epithelium is replaced by goblet cells. Remember, they increase and release mucus. So you might see lots of mucosal edema, right? Inflammatory exudates and hyperresponsiveness of the airway. So you'll see bronchoconstriction, right? And very much increased microvascular permeability, so that you'll lose a lot of fluid in that direction. So you see about 6 to 12 hours later, secondary mediated response, right? So it's going to be a little bit better to treat with, and neutrophil releasing that chemotactic factors, right, are going to be the likely cause of this secondary mediated response after the initial, right, release of extra mucus from the goblet cells and the hyperresponsiveness that's going to cause the bronchoconstriction. So the manifestations that you'll see are wheezing, tightness of the chest, dyspnea, right, a cough. The cough could be dry cough or a productive cough. Again, with a productive cough, that means that there is mucus, extra mucus being produced, and often it will be very thick, it'll be very tenacious, and it'll be very viscous, okay? A hyperinflated chest. So in a patient who is asthmatic, you will often see them from the side and notice that they are quite round. We call that they are barrel chested, okay? So they're barrel chested. And you're going to see decreased breath sounds, so very shallow breathing. And again, the wheezing is probably the most clear manifestation of asthma that you'll get from a patient, right? So in the case of a very severe attack, I want you to look of using the accessory muscles of respiration, including the scalenes in the neck. So if you see the muscles in the neck start to get tense, that is somebody who's really struggling to breathe. You might see intercostal retractions. If the person is quite thin, you might see movements in between their ribs, right? Especially if it's a child, right? Without a lot of muscle development. And then you, again, lots of inspiratory, wheezing with decreased and distant breath sounds, orthopnea and agitation, right? So tachypnea, greater than 30 breaths per minute, right? In an effort to try to get enough air in. You might also see tachycardia, right? And pulsus paradoxus, which is a change in the pulse depending on respiration, right? So wheezing is not a good indicator of airflow necessarily. You'll see that the pulmonary function test is going to show this less than 80 liters per minute. Pulmonary function as measured by the peak expiratory flow rate. That's what PEFR means. Remember, peak flow is a lot like the velocity of how much, how quickly you can get air out in a patient who is currently having an asthma attack. The velocity of how quickly they can get air out is going to be very slowed. It is equivalent to your forced expiratory volume, if you remember that from your spirometry in your physiology class. All right, so you'll see that hyperinflation, right, in your radiographical findings. So in a chest x-ray, you're going to see that diaphragm be flattened, right? You might see some physical findings, and sputum examination is going to show these charcoal-laden crystals, right? So if it's positive for charcoal-laden crystals, then the sputum, you're definitely going to have a diagnosis of asthma, right? So that's from crystallized enzymes and from the eosinophils. So the eosinophils are, you know, releasing their enzymes and granules, and you might even see eosinophils themselves in the sputum. And the Kirschmann spirals. Let me see if I have a picture. No, look them up. They're very interesting, like mucousy spirals, right? From the bronchioles in the sputum. All right, so pulmonary function test. Again, forced expiratory volume is decreased. Usually the diagnostic criteria is about 70%. There you go, less than 75%. Is if there is an FEV1, right? Which is your forced expiratory volume in 1 second, right? Divided by your forced vital capacity is less than 75%, right? Then that means that there is an obstruction, okay? So that is, again, the way we measure peak expiratory flow rate. Okay, so very important, right? So skin testing can also be done in your young patients with extrinsic asthma, so you can find out maybe what they are allergic to. All right, so ABGs, arterial blood gas, right? So during a mild attack, your arterial blood gas should be relatively normal. Remember, arterial blood gas is the amount of oxygen, the percent saturation of oxygen in your arteries. So not in your veins. So don't go trying to like hit a median cubital vein to get an ABG. You need to get to the arteries, which are usually deeper, right? So the arterial blood gas for somebody who's young should be above 95%. Up to 90 is relatively normal. Below 90 is some cause for concern. That means that there is definitely not sufficient oxygen saturating at the lung. All right, so respiratory alkalosis and hypoxemia, when the bronchospasm increases in intensity, you're going to see some lack of oxygen and getting into the alveoli and areas where we exchange gas, right? So also, if you don't get the oxygen there, usually you aren't getting the carbon dioxide out. So your partial pressure of carbon dioxide will also be elevated. That is very clear sign that the patient is getting worse. Because again, all of those should be relatively normal during a mild attack. Right? So bronchial provocation tests, so they may use methacholine or histamine and see if the bronchioles respond with constriction, right? So bronchoconstriction. And then a CBC with elevated white blood cells, particularly eosinophils. Eosinophils are basically the ones mediating the IgE release. All right, so what is the treatment? Avoiding triggers, right? Environmental control, like dusting and purifying the air, preventive therapy, things like stop smoking or avoiding secondhand smoke. Very strong odors or odors that you know trigger the asthma, right? Early treatment for respiratory infections. Because remember, I want you to think, if you have an increased mucosal production in your lungs, okay, you are going to be much greater and much more susceptible to getting respiratory infections. So an upper respiratory tract infection may kind of creep downward for somebody who's asthmatic, because mucus is a beautiful breeding ground for infections. Okay, so that's why you'll see often, patients that are asthmatic suddenly become sick with what is a lower respiratory tract infection. So desensitization, right, that allergen specific immunotherapy for those who have that more extrinsic type of asthma. All right, so medications, right, oxygen therapy, small volume nebulizers, the beta-2 agonists, which, are kind of my favorite, your Ventolin and albuterol, right, corticosteroids, which are not my favorite, right, some leukotriene modifiers and mast cell inhibitors, all are possible treatments for asthma. For status asthmaticus, right, that severe attack that is very unresponsive to routine therapy, you might see epinephrine, subcutaneous terbutaline, which terbutaline you can also get in nebulizer form, right, aminophylline, intravenous corticosteroids, and then oxygen therapy, if necessary, even with mechanical ventilation. All right, so you can see here all of the different methods by which you can block your mast cell responses and other responses at the asthma, to block asthma. So, for example, parasympathetic nervous system, right, can be blocked by ipratropium, right, which can be delivered via an inhaler form, right? Chemotaxis of neutrophils blocked by corticosteroids, so things like prednisone. All right, so many asthmatics, particularly those with adult onset intrinsic asthma, are gonna have corticosteroids being prescribed, right? You will also have other corticosteroids that can block mast cells as well. Diphenhydramine, right, which is your regular, Benadryl, right? You're gonna block the histamine, right, reaching and attaching to its receptors at its target tissue. You might see those beta agonists, right, theophylline and other muscarinic antagonists that are going to prevent the bronchial smooth muscle contraction. And then other corticosteroids to reduce the edema and mucus secretion. Right, and then you also have your receptor antagonists here, your leukotriene receptor antagonists, Zavirculast, right, and Montelculast, which is like Singulair. Right, so then you have also bronchitis as another one of our obstructive disorders, right, where you have an acute inflammation of the trachea or bronchi, right? So the causes could be viral or non-viral, smoking, inhalation, irritants, even allergic reactions or heat, right? So asthmatic bronchitis you might see also in bronchial mucosa in children. And that can also lead to obstruction and respiratory distress and wheezing. So it's kind of like both, right? So where does bronchitis come from, right? So The airways are narrowed from capillary dilation. Okay, so they come inflamed, and they have fluid exudates, right? A lot of inflammatory cells, which also infiltrates, which also can narrow, right? They all have this increased mucus production. Loss of ciliary function, and loss of portions of the ciliated epithelium. And I want you to look at those last two, right? So and also the mucus production, but that could happen due to other reasons, right? But the loss of ciliary function often comes from smoking. And you know that people who are smokers get not even acute bronchitis, they get chronic bronchitis. So we'll talk a little bit about that afterwards. All right, so clinical manifestations, usually there's a cough, which could be productive or non-productive. Substernal chest discomfort with possibly even a low-grade fever, some sore throat, a post-nasal drip. You're going to see fatigue, right? And it's usually self-limiting, right? The clinical presentations is a recent onset of cough. So you might hear cough, and again, oftentimes even a dry cough, if it really has nothing to do with extra mucus production, right? So a chest x-ray is often necessary to make sure that there's a clear distinction between acute bronchitis, right, and pneumonia, because pneumonia is going to have lots of, like, you know, whitish stuff being seen in the lungs, which is fluid that in the alveoli. All right, so treatment is usually no treatment if it's viral, but antibiotics if it's bacterial. Codeine is good for cough, increasing fluid intake. Avoid smoking, and using a vaporizer in the bedroom is good for bronchitis as well, to kind of ease that very dry and almost painful aspect of the bronchitis, right? So chronic bronchitis, like I mentioned, most of it is from cigarette smoking, but it also could be from repeated airway infections. And oftentimes you might see a genetic predisposition or even inhalation of certain physical or chemical irritants. If it goes on for a long time, that can also develop a chronic bronchitis, right? So the etiology is, you'll see that type B COPD blue bloater, which we're going to talk about in just a second, right? And so you can see what are some of the characteristics of the blue bloater, right? And then hypersecretion of bronchial mucus. You're going to see a chronic or recurrent, and usually it's a productive cough because now you have enough mucus, right? And particularly over 3 months and even into the years, right? Into 2+ years. Persistent and irreversible, particularly if it is paired with emphysema. You'll see the 1 to 2 male to female ratio. So for every 2 females, right, 1 male has that. That's what that means, okay? And you'll see it again in usually people who are above the age of 30 to 40 years old. All right, so so what is the pathogenesis of the chronic bronchitis, right? So now you have inflammation and swelling of the bronchial mucosa, and usually that results in scarring. So you'll see elevated IL-8 levels, which are going to cause neutrophil activation and the CD8 T lymphocytes. And then, right, so anything that extends into the alveoli and preventing proper oxygenation. So the bronchial mucus glands and the goblet cells are going to undergo hyperplasia. So we're making new cells, right, which increases the mucus production and obviously forms those mucus plugs. Then you'll also see bronchial wall thickening, and anytime that you'll see bronchial wall thickening, it's going to become harder. Again, it creates greater amount of resistance, right? So you're going to have to work harder to breathe, right? And then the O2 demands are going to be greater. So then you're going to have a ventilation perfusion mismatch, right? Where you have hypoxemia, so low amount of oxygen because the oxygen can't get in, and hypercarbia, right, or hypercapnia, if you've seen it like that, where there is harder for the carbon dioxide to get out, right? So that all increases the pulmonary artery resistance. And then that can lead to pulmonary hypertension, right? So pulmonary hypertension and inflammation in the bronchial walls, right, with that vasoconstriction, right, of pulmonary vessels and arteries. This could be due to right-sided heart failure and may occur in with high pulmonary resistance. Right, so this also could be destruction of the bronchial walls, right? So that causes something called bronchiectasis. So there's a dilation of the airway sacs, right? So you'll see that the in a patient with bronchiectasis, instead of the bronchial tree, think about your bronchial tree. Remember that it has the little branches, right, from the primary, secondary to tertiary bronchi. So think of you putting like the appearance of your bronchial tree, instead of getting smaller, it's actually gonna be like almost pearl-like, or it's going to be very dilated. So instead of the tree getting smaller, you're gonna have a much wider black space within that bronchial tree because it's dilated, right? So the dilated sacs, right, contain all these pools of infected secretions that are very hard to clear themselves, and so you're gonna have further infection. And then that can even make its way into the lymphatics or venous drainage in the and other areas of the body, including the brain. So chronic bronchitis, right? The typical patient for chronic bronchitis is overweight. It's commonly associated with emphysema, right? Shortness of breath on exertion. You have excessive sputum. You have a chronic cough, and very severe in the mornings, more so, right? And then evidence of excess body fluids like edema and hypervolemia, and cyanosis, which can be seen by like a darkening or bluish tint to the lips as a late sign of chronic bronchitis. All right, so these are some of the clinical manifestations of your blue bloater, right? You'll have these patients with excessive body fluids, a chronic cough, shortness of breath on exertion, increased sputum, and cyanosis, right? So this is usually your chronic bronchitis patient. So you'll see your chest x-ray with these bronchial markings. You'll see congested lung fields, enlarged cardiac silhouette, and even some pulmonary infection like scarring, right? Their pulmonary function tests are often going to have a normal total lung capacity, but their residual volume, which is the amount of air that stays in their lung, is usually greater, and their FEV1, remember the forced expiratory volume in 1 second, is going to be decreased. Their arterial blood gas is going to show, obviously, a lower oxygen and higher carbon dioxide, because the oxygen can't get in, the carbon dioxide can't get out. And so you might see atrial arrhythmias, and then you might see a right ventricular hypertrophy because there's a ventilation perfusion mismatch, and that can cause right-sided heart failure, right? So you have that inability, that backup, because the inability of you to oxygenate the entire lung. And as a side effect, right, due to the hypoxemia, right, with the oxygen not being able to saturate, right, the your hemoglobin, so your hemoglobin saturation is down, you're going to see, your kidneys are going to detect this as a hypoxia, right, and hypoxemia, and so you're going to see people making more red blood cells, so you might see a polycythemia due to that, right? So what are the treatments for chronic bronchitis, right? You're going to want to block the progression of the disease, if that's possible, right? So if it's occupational, definitely removing yourself from that environment, and then returning the respiratory functions to as much as possible. So being that we may give multiple medications in order to, right, increase the amount of oxygen that's getting there, decrease the amount of carbon dioxide in the blood. Because remember, if you have an increased amount of carbon dioxide in the blood, I'm going to throw this out there, what's going to happen to your bicarbonate buffering system if carbon dioxide is elevated? I want you to go back and look at your carbonic acid buffering system and tell me what happens, because we're going to discuss this in chapter 24. Right? And so obviously the ability for your patient to return to their normal activities of daily living. Right? So beta 2 agonists, again, like albuterol and Ventolin. You might also see anticholinergic bronchodilators, cough suppressants to reduce that, and then antimicrobial agents if necessary to treat the bacterial infections, corticosteroids like prednisone, and theophylline products. All of those to treat that chronic bronchitis. It may need oxygen therapy and mechanical ventilation, right? So management, obviously smoking cessation, but that doesn't always work. Bronchodilator therapy, right? And reduction of exposure to any irritants. So what are we talking about here, right? So managing, right? A chronic bronchitis requires adequate rest, proper hydration, right? Influenza and pneumococcal vaccines all the time. And then a physical reconditioning. So starting to increase things like walking and biking with alternating rest and exercise, with walking being the best type of exercise to manage this chronic bronchitis. All right, so emphysema. Emphysema is going to be your type A COPD called the pink puffer. So you have the chronic bronchitis as your type B COPD, blue bloater, and your type A COPD, pink puffer, is going to have very different manifestations, right? So remember, emphysema, so you'll see destructive changes in the alveolar wall. Remember that your alveoli look like little grapes. So instead of having the entire wall all the way around the grape, it's like you merge the grapes into like one gigantic grape. And with less or decreased amount of membrane, there's less membrane for you to exchange carbon dioxide and oxygen. Right? So it's what we call that enlargement of the distal air sacs. And damage in this case is irreversible. So you're not going to be able to give any medication. It could be associated with chronic bronchitis. Right? It also could be genetic. All right? So emphysema is mostly caused by people who are smokers, right? Or are exposed to high pollution. And that even could be in certain occupations like mining, welding, or working with or near asbestos. And then the alpha-1 antitrypsin deficiency is the one that's more on the genetic side. Now, alpha-1 antitrypsin deficiency is usually gonna be not a problem because you're not born with the disorder. You're actually going to make this disorder much worse by smoking or being exposed to secondhand smoke. All right, so pathogenesis, again, it could be genetic, right? These enzymes, right, from the neutrophils and macrophages leading to the alveolar damage, right? And then what happens is that smoking causes this alveolar damage because of these proteolytic enzymes, and it inactivates the alpha-1 antitrypsin, which normally is protective. Right, so if you reduce, right, reduce this capillary bed, right, in the pulmonary, in the lung, the exchange of carbon dioxide and oxygen is going to be impaired. Right, so there also is going to be a loss of elastic tissue in the lung. So air becomes basically trapped in the distal alveoli, right? So that kind of traps air. And so that even thins the walls even more and looks like cysts-like. So you can see that in the normal alveoli, a bunch of little grapes. Now they're like distended, much enlarged, like one big grape. Again, remember what you're looking for in alveoli in emphysema is the decrease in the surface area. The surface area has been decreased. All right, so you're going to have central acinar, right, which is associated with smoking and chronic bronchitis, which means in the center, right, as it reaches the lobar, or pan-acinar, which is basically complete destruction, right, all the alveoli, and you might see the paraseptal. These classifications may not be critical for you to know, so I wouldn't stress too much time on that. Right, so you can see there the different types of emphysema. Right, so progressive exertional dyspnea, right? So usually you're going to see a person who's thin. Why? Because they have this increased caloric expenditure, right? Because they are having this increased respiratory effort. So they're really not able to consume enough calories for that extra respiratory effort. You'll see a lot of accessory muscle usage, again, like in the neck. And then you'll see pursed lips. So the lips, think when you're trying to breathe, that you would put your lips out, right? That you'll see that. And then cough, either minimal or absent. So this doesn't really have to do with any type of movement of mucus. You might see clubbing in the tips of the fingers as well, and that barrel chest that I mentioned before. All right, so again, use of accessory muscles to breathe right here in the neck, the pursed lips, right, when actually trying to breathe. So this gentleman here is obviously not trying to breathe, but notice he is on a nasal cannula because, you know, they have a decrease in the oxygen that gets in due to the decreased surface area to exchange carbon dioxide and oxygen. So oxygen can't get in and carbon dioxide can't get out. Right? So minimal or absent cough, leaning forward to breathe, barrel chested, distal clubbing, and I'll tell you what that is in just a second, and dyspnea on exertion being one of the later signs. All right, so some of the pulmonary function tests, right? Increased functional residual capacity, not just residual volume, right? You'll see residual volume, right? An increased TLC. So remember, with the chronic bronchitis, you had a normal TLC. So you also will have a decreased FEV1 and FVC. Remember, that's a forced expiratory volume in 1 second and forced vital capacity. You will also see hyperventilation, low flat diaphragm. You might see some blebs or bullae throughout, right? Like bubbles, narrowed mediastinum, and then a narrowed vertical heart. Remember, in chronic bronchitis, you saw right ventricular hypertrophy. So you're going to see an enlarged heart with an enlarged mediastinum. All right, so you might see a normal EKG with tall P waves, sinus tachycardia, which is obviously if you have very little oxygen, you're going to have an increase in your heart rate, right? And then supraventricular arrhythmias, right? And then remember, that's before the ventricle. So remember that the EKG is going to be at the ventricle is QRS complex. So anything before the QRS complex would indicate a supraventricular arrhythmia and ventricular irregularities. You might see a mild decrease in the, this is, remember, the partial pressure of oxygen, but a normal PCO2. However, it will be elevated in late stage emphysema. So the diagnosis can be made with a patient history that is, you know, asking all of the right questions. Some typical findings, you're going to see thin, wasted type individual hunched forward using accessory muscles with lack of crackles and rhonchi, so no crackles, and decreased breath sounds, prolonged expiration, decreased heart sounds, hyperresonance in the lungs, right? And then decreased diaphragmatic excursion, so movement, and then chronic morning cough. Oxygen therapy, smoking cessation, and some beta-2 agonists, right? And then anticholinergic bronchodilators are all good medications and treatment for people with emphysema. Cough suppressants, antimicrobial agents to prevent the infections, theophylline, and other corticosteroids you might see as well. All right, so the bronchiectasis is that dilation in the bronchial wall. Remember, this could be seen in addition to other things. So you might see bronchitis and bronchiectasis, right? It is quite rare, but it could be congenital, so it could be born with it. So you might see more risk in children, and it is associated with cystic fibrosis. And so it is both obstructive and suppurative. So you're making pus, right? So you could see here, this dilation looks kind of like that pearl-like appearance. You see how it's kind of varicose, okay? So cylindrical, saccular, or varicose. Those are the types of dilatations, right? So pathogenesis, right, is a recurrent infection to the bronchial walls, right, leads to this persistent dilation. You have bronchial wall thickening, and inflammation then results in the destruction of the wall. So then, the ciliated epithelium is also going to be lost, and then it transforms that cell lining. Remember that squamous cell lining, when you lose the ciliated epithelium. Remember, pseudostratified ciliated epithelium is going to be dominant in your respiratory system. However, when you lose ciliated epithelium, you replace it with squamous cells. And so you'll see that squamous cell transformation and then pus formation. And then that leads to obstruction, and thus why bronchiectasis is a COPD as well. Right? So a persistent, daily, chronic, productive cough that's quite purulent has a foul-smelling green or yellow sputum. So you might see hemoptysis, so they're coughing up blood, fever, night sweats, right? Rhonchi, halitosis, skin pallor, and digital clubbing, which again, I'm going to show you a picture in just a second. Right? So prolonged decreased oxygenation causes clubbing. So the tips of the fingers become clubbed. Kind of like the clubs that Fred Flintstone would carry around and hit, other people with on the head, right? And so those are associated with lymphocytic extravasation, right? Increased vascularity and edema. So you'll see that's pretty bad for disease. So the normal nail angle is about 160 degrees. So mild clubbing kind of flattens out the tips of the finger, and then your advanced clubbing makes this angle go basically beyond 180 degrees to maybe more like 190 or 200, which is past a straight line. So normal, you have that little triangle or diamond shape between the ends of the nails. In clubbing, you're going to see that the cuticle of the nail, right, the hyponychium, is going to actually be touching. All right, so the diagnosis is usually in the chest x-ray, which you can see the cysts. Also, a history of chronic productive cough can lead you in that direction of bronchiectasis, right? So you'll see a pulmonary function test with decreased airflow and vital capacity, with a arterial blood gas of decreased partial pressure of oxygen and increased partial pressure of carbon dioxide. And the CT scan is probably the best, so you can get a very good image of what's going on in the chest. So what do we do? Antibiotic therapy, right? Bronchodilators, even chest percussion. So chest percussions are going to be like basically tapping to try to loosen the mucus, right? And so you might even need to get into a particular position to get drainage to improve, right? Properly hydrating, because if you're not properly hydrated, your mucus can become very sticky, right? So proper nutrition, non-smoking, right? Regular exercise is good, right? To help move that mucus, right? Anytime a child might be born with this, childhood immunizations, particularly for influenza and pneumococcal vaccines, and like the Haemophilus influenza type B vaccine as well, right? anything that would prevent there from being any type of pneumonia. Remember, pneumonia can be caused from many different microorganisms, not just the pneumococcal ones. That's usually streptococcal, okay? Streptococcus pneumoniae is the one that the pneumococcal vaccine is protective against, right? So bronchoscopy with lavage and even surgical removal if necessary. All right, another one, obstruction of the airway lumen is bronchiolitis, right? Where there is a widespread inflammation of the bronchioles due to infectious agents, right? So usually related to allergic reactions, particularly RSV, right? Respiratory syncytial virus, which is the most common cause, that is going to be high, in the population around the winter to spring months, and very, very common to see the RSV attack children under the age of 2 because they have no natural immunity to that and they've never been exposed to that. By the time we're 2 years old, most of us have been exposed to that, and so for some people, exposure to RSV might cause you to have a chronic condition like bronchitis or asthma, and for some kids it just clears up. It really just depends on the way that your inflammatory processes occur, and maybe the way that you can deal with those changes, the allergies that may have developed, and so on, right? In adults, smoking, toxic fumes, and immunosuppression can also lead to bronchiolitis. Right, so pathogenesis is usually necrosis of the bronchiolar epithelium, right? So proliferation and necrosis. So thick, tenacious mucus, right? Airway obstruction, atelectasis, which is basically lung collapse, and you'll see hyperinflation as well. So exudates. So the exudates, there's just so much of them, it displaces the surfactant, and the surfactant then can't do its job, and so every time that you're exhaling, particularly if you're coughing, you're going to, stick the alveoli together and they will not be able to reopen. So, some chemical mediators between white blood cells also can produce the bronchiolar constriction, inflammation, right? And that inflammation can then cause fibrosis, which makes it even more, right? So fibrosis causes there to be less elasticity in the lungs. And then goblet cell metaplasia, like we've seen before, where you have more mucus cells, and then bronchial muscle mass increases as well. Right, so you might see a severity in the course from very mild to even fatal. So bronchiolitis can be very bad, usually wheezing with bronchospasm, right? With crackles, decreased breath sounds, retractions, increased sputum, dyspnea, tachypnea, and low-grade fever. All right, so elevated white blood cell count, chest x-ray with enlarged air sacs and interstitial infiltrates, atelectasis, again, lung collapse, and hyperinflation. And then your PFTs indicate a severe obstruction to airflow, and nasal swabs to determine if RSV is the cause. So what are some of the treatments for this? Humidified oxygenation, bronchodilatory agents, corticosteroids, sedation for anxiety, hydration, antiviral, antibiotics, smoking cessation, and particularly avoidance of secondhand smoke. And for RSV, for healthcare workers, wearing eye and nose goggles. So cystic fibrosis. So cystic fibrosis then is an autosomal recessive disorder. This is genetic, right? And so the exocrine glands make a very sticky mucus, right? So it's the most common genetic lung disease in the U.S. There's many different genes or alleles that can be found. There's some alleles are found in, certain ethnicities. Other alleles are found in different ethnicities. So there is probably about 200 actually different alleles that have been found for cystic fibrosis. And all of them can be a little bit different in their severity, right? So hypersecretion of abnormal thick mucus, right, that's going to obstruct the exocrine glands and ducts, does not only affect the lungs, also affects the pancreas. This is definitely a genetic disorder that decreases the life expectancy. This book says 31. I think that the latest numbers have shown to be more like 36, but still not reaching what we consider middle age. Okay, so it's definitely going to shorten their life expectancy. And again, because there's a blockage of exocrine glands, it could be either the lung coming from a lung infection, or it even could be from the pancreas and suffering pancreatitis and other, problems due to the pancreas. So it could be either one that causes ultimately causes death. So dysfunction of the CFTR gene, right? And so basically the CFTR is encoding for a chloride channel, and that chloride channel is going to be defective. So because that chloride channel is found in the lungs and the pancreas and the sweat glands, that's going to have abnormally produced sweat on the skin, and then obviously in the products in the lungs and the pancreas are going to be altered by the fact that there's no saline layer that allows for these products to move through very quickly, right? Primarily affects the pancreas, intestinal tract, sweat glands, and lungs, and in males causes infertility. So you'll see that as well. So unfortunately, it's genetic. So if it is passed down, the fact that there is some infertility does kind of lower the chances of a male at least passing it down to the female, to his children. And then the higher concentration of sodium and chloride in the sweat. So you can do a sweat test to actually use for diagnosis in salivary and lacrimal secretions, right? So so excessive secretions in the GI tract, so GI tract enlarges, and you'll see eosinophilic mucus kind of plugging up the glands and ducts of the GI, causing dilation and fibrosis, right? So leading to decreased production of pancreatic enzymes, which can then cause a undernutrition, because even though they may be eating food, they're not actually breaking down, right? Because their pancreatic enzymes aren't completely functional, and so it decreases the breakdown of the food, so you're not absorbing any of the nutrients that you're consuming. So you'll see fat and protein in the stool, right? So the bronchopulmonary system can also be affected by that thick tenacious fluid, right? So the chloride channels, since they're not functional, they make a very viscous fluid, and it can't move because the saline layer that usually permits this mucus to move is going to not be present, and so the mucus becomes very adhesive. It sticks very, very sticky, right? So then that causes airway obstruction, again can lead to atelectasis, right, and hyperinflation, and obviously ciliary action is going to be decreased because all this mucus is stuck on it, right? And so the mucus, obviously, anytime there's extra mucus, it provides a beautiful breeding ground for pulmonary infection. So again, pulmonary infection is usually the ultimate cause of death. However, it could be even pancreatic dysfunction, right? So a child with a history of cough, thick tenacious sputum, recurrent pulmonary infections and bronchitis, dyspnea, tachypnea, sternal retractions, unequal breath sounds, right? Crackles and rhonchi, barrel chest, usually hyperresonant, to percussion, and digital clubbing later in the manifestations. One thing that you can kind of rest assured is that most states test for cystic fibrosis at birth, so that a patient with the proper diagnosis of cystic fibrosis can then be treated accordingly. So if you look up something called www.babiesfirsttest.org, it is a website that tells you all of the genetic tests that each state tests for at birth. And cystic fibrosis is tested for at birth in the state of Florida, as it is in most states. Right? So again, pancreatic insufficiency, cirrhosis of the liver, diabetes, gallstones, nasal polyps, and failure even of development of the vas deferens in males. So you'll see depleted fat stores, fatty stools, steroiduria, anorexia, and even a decreased growth rate in children with a height, weight, and head circumference that's lower than other children. So hypoxic, right? Hypoxemia, in the blood, right? Hypoxemia in the blood and hypercapnia. And you'll see that in the ABG, in the pulmonary function test, a decreased vital capacity, and even tidal volume, and then affected airflow. Increased airway resistance and increased functional residual capacity. The chest x-ray shows patchy atelectasis. You might see bronchiectasis and cystic lung fields, which are areas where there's an accumulation of lots of mucus. Right? So the sputum is collected, right? And sampled, and then the 72-hour stool collection to see the fat absorption, the sweat test, right, to see elevated sodium and chloride levels, and genetic testing for that genetic marker AF508 confirms the diagnosis. So aggressive treatment for all respiratory infections if the person has cystic fibrosis, right? Postural drainage, right? So again, this is either cupping or even physiotherapy and forced expiratory techniques. So they got to learn how to kind of get rid of that extra mucus so that they can breathe properly. Right? Bronchodilators, right? And then deoxyribonuclease 1, right, which is going to help digest extracellular DNA, which is also present in this very viscous sputum. And then antibiotics, very high dose in the case of bacterial infections, and the influenza vaccine to prevent that pneumonia due to the flu. Nutritional therapy to increase the amount of nutrients available, right? So unrestricted fat consumption. They have high protein diets with vitamin supplementation of especially their fat soluble vitamins. Sometimes they might even need exogenous pancreatic enzymes, and so their intake should be about 150% of normal, since they are going to not be able to absorb most food. So you might see even enteral feedings or IV feedings. You might see a heart, lung, or even lung transplant in cystic fibrosis patients. And then another obstruction of the airway is acute tracheobronchial obstruction, right? Is when there is some sort of aspiration of a foreign body, most commonly in the right lung. And I don't know if you remember why, but your right primary bronchus, is actually in a facing down and is actually wider than the left primary bronchus, which is actually pointing more of a 90-degree angle, and is smaller. So you'll see most aspiration, everything gets lodged at the right primary bronchus, right? And obviously this requires immediate treatment, right? It could be also due to a malpositioned endotracheal tube, laryngospasm, epiglottitis, trauma, swelling, post-surgical blood clots, compression of bronchus or trachea, maybe due to a tumor or enlarged lymph nodes. The obstruction may be complete or partial. Right, so in a complete obstruction, right, there's no air movement going in and out. There's an inability to talk, a tachycardia, cyanosis, right? Obviously, they're going to lead very quickly to unconsciousness. All right. If there's a partial obstruction, you might see stridor, right? So difficulty getting breath in, usually very evident with muscular, right? That neck muscles being visible, sternal and intercostal retractions, wheezing, nasal flaring, dyspnea and tachypnea, tachycardia, and use of accessory muscles and cyanosis. Right, so what is the diagnosis? Right, there's a hypoxemia and hypercarbia. Right, and then there's a location of obstruction, determination